I am from New Jersey, so I can say that. So today we're going to start by talking about risk assessment in the era of novel agents, and I actually think that this is a very important topic in the future, and I'm really going to sort of present what in essence is going to be a very different style of presentation, one that I think we can all use in our practices moving forward. It's this one? Okay. Oh, okay, I got it. So we're all very familiar with this slide from MD Anderson looking at the survival of CLL patients by the decade. We actually look like we're doing quite well with a marked improvement from pre-1980 to the 2000-2010 decade. The big issue though is when you look at these data and control them for Rye stage, and those were data from MD Anderson. This study was actually done in Europe, so it's using Binet stage. There's actually been no improvement in our outcome stage by stage, and that really what in essence we're seeing is lead time bias. So we're diagnosing a higher percentage of patients in Binet stage A, and patients are therefore living longer. But stage for stage, with the exception of those few patients who benefit from more aggressive supportive therapy and perhaps clinical trials in Binet stage C, our patients are still living the same. So one of the things that becomes very important is how do we prognosticate? How do we try to decide who are these patients that really need something more and who are these people that are going to be fine with nothing? And I do think that one of the areas that we really need to investigate is watchful waiting. And I think that there's going to be a realization about the biology of the disease that really can help us understand who is going to need to be treated very differently from the others. So here's a very partial list of prognostic markers. I actually compiled this list probably about 5 years ago. I stopped adding to it because I ran out of space on the slide. And clearly you can see that we have a tremendous number of prognostic markers, almost all of which are of no help. And I really want to emphasize that. So these are the clinically relevant ones, the ones that we really use in clinical practice. And you can see the traditional ones, which I think of as being more organism-based, and then the novel ones, which are more molecular or cell-based. And the one on the bottom, of course, is NGS for next-generation sequencing. There's not really a set panel, and I use that just to mean the sequencing of anything from BRC3 to SF3B1 to Notch mutation. And so with all of these prognostic markers, you can generate very nice curves. And so here we have curves separating patients based upon immunoglobulin G mutational status, interphase FISH, ZAP70, and CD38. The problem with all these curves, and the problems with all prognostic markers, is that you can only tell how a population will do, never how the individual. So you can never tell a person that that's them on the mutated curve versus being that person on the unmutated curve. And so you really can't tell them what they need to know, which is how well are they going to do. As a population, you can always tell how a population will do, but never the individual. So when we look at why we need prognostic markers and what role they can really play for us, we really talk about CLLs being a disease of tremendous variability. But what's really most important, and what really is a big disservice that our internists often do, is 70% of patients die from CLL. Most patients show up at my office being told by their internists they'll have nothing to worry about. So that's a very important thing to keep in mind. Now, hopefully that's something that will be changing, but along those lines, our therapies have a great deal of toxicities. So we have patients who are going to be living a long period of time, and certainly exposing them to toxicities that are going to have an impact on their quality of life becomes very important. And of course, patients look to these prognostic markers as if they're, God's truth, and then of course we end up with a tremendous amount of anxiety. I had a patient walk into my office a couple of weeks ago telling me that he can't believe he's only going to live 83 more months. So this is really the most important prognostic marker that we have. So this developed in 1974 is really the only one that tells us really how to care for our patients, when to care for our patients, and it really provides us the most information. So when we talk about prognostic markers, what are some of the problems that we have? So are they helpful? And I show you the curves, and we don't know where on the curves individuals are going to fall, but we also have a lot of issues where prognostic markers are just of no help. So the first one are discordant values, right? Patients always want to choose which prognostic marker they want to believe in. So they're unmutated in ZAP70 negative, or they're mutated in ZAP70 positive. Likewise, we have a lot of exceptions, and a lot of those exceptions may actually be responsible for the curves not being perfect. And so one day, maybe if we figure out all the exceptions, we could really know what we're dealing with. But then, of course, we have this whole entity of post-treatment prognostic markers. And the question, of course, becomes, what's the value of a post-treatment prognostic marker? Now, if we had an intervention post-therapy that we were going to use, then yes, it could be very helpful. But until that time, we really don't have a use for post-treatment prognostic markers. So here are the curves looking at ZAP70 and mutational status. And you can see here that ZAP70 trumps immunoglobulin G mutational status. So if you're ZAP70 negative and mutated, you're going to do like the ZAP70 positive people. And if you're ZAP70 negative and unmutated, you're going to do like the ZAP70 negative people. Likewise, this is a very interesting group of people. These patients have the V gene 3-21, which is about 90% of the time mutated. So looking at the mutated 3-21 patients, you could see here that their median survival is 63 months, actually shorter than the patients with unmutated immunoglobulin genes. And what's interesting is the majority of these patients who are VH 3-21 and are mutated actually have what's called subset 2 BCR receptors, and in essence have really a very high affinity for a particular group of antigens. And so this does also teach us a lot about biology. But once again, having a mutated CLL and ending up with a median survival of 63 months is certainly something that's going to get us into trouble if we start using our prognostic markers. And then likewise, here's the MRD assessments from the CLL8 study by the German CLL study group looking at fludarabine cyclophosphamide to fludarabine cyclophosphamide and Rituxan. And in essence, how well you do predicts how well you're going to do. So this was a brilliant piece of work. Of course, we really can't use this to take care of our patients because this is something we only get after we give the therapy. So where do we use, or where can we use clinically prognostic markers? So from our CLL4 study, we know that patients who have fludarabine cyclophosphamide as treatment are going to do far better than the patients who have fludarabine alone. Now, when you look by interface FISH abnormalities, the vast majority of the benefit was really just due to the differences in the 11q deleted patients. So all of a sudden now, if you're 11q, you need FC. But if you're not 11q, fludarabine by itself is going to be far less toxic and equally efficacious. Unfortunately, if you're 17p, nothing's going to work. So obviously, this is a sign that you want to avoid exposing these people to the toxicities of chemotherapy, since there really isn't going to be a tremendous advantage. So clinical use of prognostic markers today, we're still using watch and wait. We're not intervening earlier on patients because of their prognostic markers. And these are really where we can actually use our prognostic markers to determine therapy. So the question is, in 2017, what about B-cell receptor antagonists? So when we look at prognostic markers and B-cell receptor antagonists, and this is the data from John Bird's New England Journal paper, the 1102 study, which was the large phase 2 study of ibrutinib in previously treated CLL patients, you could see that no prognostic marker predicted response with the exception of immunoglobulin G mutational status. Now what's interesting is the patients who had a mutated immunoglobulin gene had a lower rate of responding compared to the unmutated. And this really sounds unexpected. As it turns out, it really was because of a delay in clearance of the lymphocytosis. And when you look at the data 6 months later, everyone caught up. So in the era of BCR antagonists, none of our prognostic markers predict outcome. But I'd like to really emphasize, we've always been using prognostic markers to look at response. And we now got to start looking beyond response. So no more of a benefit to using prognostic markers in determining response. But the question is, what about PFS, progression-free survival? So these are the patients from MD Anderson treated with the FCR 300. These are 300 unselected patients treated in, routine clinical manner. And you can see here in red the overall survival and in blue the progression-free survival. And a lot of people are focusing on this plateau here, which represents basically a 30% progression-free survival at 10 years. And the question becomes, who's in this platform, or who's in this plateau, and can we identify them and say that these are people who have a 30% chance of being cured from their CLL using FCR, and that is something worth striving for. But what happens is when you look at this plateau, all of a sudden you realize that 74% of that plateau are going to be mutated immunoglobulin gene patients who may have done well anyway. And then all of a sudden you have to wonder, well, we're exposing the people who have the best outcome to the most toxic therapies. Is that really a good thing? And you can see here in the patients who are unmutated that you really end up with a plateau of only about 10%, which is certainly better than not having a plateau at all, but it's still certainly something that we need to do a lot better at. But when we use chemotherapy, we also have the downside. And this is just to remark on the risk of MDS and AML that we see in these patients, in particular when we use fludarabine and cyclophosphamide in combination. And when we look at these 300 patients in general, what we see is that 8% developed a Richter's transformation, 6.3% developed another hematologic malignancy, most commonly secondary MDS and AML, and 21% developed other cancers. And though the breakdown isn't provided, these really aren't just cutaneous skin cancers. These are, melanomatous skin cancers and other lethal malignancies, not the ones that we usually see in our CLL patients. And 40% of the deaths of the patients in this study are associated with secondary tumors, acute leukemia, MDS, or a Richter's transformation. So our therapies do have a lot of toxicities. So the questions for the future, one is, which patients need more therapy? Obviously, we have effective therapy. We don't want to let it fall by the wayside. And the question is whether or not we can intervene earlier in a group of patients to possibly impact upon the outcomes. So currently, high-risk disease is characterized by, IGVH being unmutated, ZAP70 positivity, or deletion 11q or 17p. I want everyone to keep in mind how we're going to hopefully change that at the end of the talk. So I'm going to actually look at the PCYC 1102, which is a phase 2 study looking at ibrutinib in patients with CLL who are either relapse refractory or treatment naive and over the age of 65. The patients were originally randomized into arms of 840 milligrams once daily or 420 milligrams once daily. After we really didn't see a difference between the 840 and the 420, all patients were sort of folded into basically 420 milligrams once daily. And when you look at the baseline characteristics, you could see here in the relapse refractory group that we really have a very significant mix of patients, but this is what I really want to emphasize, a 35% risk of 17p and 11q. And in the idelalisib pivotal study, that number was 45%. So we're dealing with a feature that actually is probably about 4 to 6% at diagnosis and increases with treatment. And this really is the most feared prognostic marker. So I do like to emphasize that most patients get from this to this through chemotherapy. So when we look at the response rates across the different cohorts, you can see here that the response rates are all quite good in the 87 to 89% range, with a mix of PR with lymphocytosis, partial responses, and complete responses. This bar is moving because over time, some of these PRs are becoming CRs, and I really have to emphasize progression-free survival becomes the most important measure, in particular with these patients. So here you can see overall, in the treatment-naive group, we've had 1 patient progress, and we've had 6 patients come off for adverse events. So 1 progression, that was a 17p deleted patient who developed a Richter's transformation at month 8, likely pre-existing. And then you can see in the relapse refractory group that we're dealing with progressive disease of about 33%. So it's interesting, there really is a significant difference in the efficacy of ibrutinib, treatment naive versus relapse refractory. And here you can see the different curves. So the question is why? And is this something that we can actually impact upon? Is there something about using the drug up front that may actually be able to help us avoid running into the problem of having people progress on ibrutinib? So I want to talk about two types of progression. The first one is what I'm going to call CLL resistance. And these are patients who have CLL, respond, and then progress and still have CLL. And we have good data from Ohio State that actually discusses that 80% of these patients will have single base pair mutations in either BTK or PLC gamma that allow impair ibrutinib's efficacy. The other 20% we don't know, but I suspect it's going to be a similar process. The second type of progression is going to be a transformation. So this would be primarily to a diffuse large B-cell lymphoma, though we are seeing an increase in Hodgkin's disease as these transforming events. One of the problems, of course, is our novel agents are ineffective in aggressive lymphomas, and so we end up with these transforming events actually really emerging on these agents. So two types of progression, CLL versus Richter's, and the question is if we can identify these patients ahead of time, maybe treat them differently. So here's the cumulative incidence of progression on ibrutinib, and you can see here the progression rate. CLL progressions tend to occur late, whereas the Richter's transformations tend to occur early, and you can see the curves here. So this would suggest that biologically there might be something related to the disease that sort of indicates who's going to develop a Richter's transformation. And then the question, of course, is that we have a single base pair mutation in one cell, and you need that time for that cell to progress. That's going to certainly take a period of time as well. So when we look at risk factors for patients who progress on ibrutinib, I really want to draw attention to 17p deletion and complex karyotype, because I think those are going to be two of the most important. It's important to remember that complex karyotype is not what can routinely be obtained. These are actually special stimulated karyotypes, and not the cytogenetics that we routinely get. And when you look, you could see that 17p and 11q deleted patients have a markedly worse performance on ibrutinib in the relapse refractory setting. So remember, in the treatment naive group, we only had two 17p deletions, and it turns out the second one has progressed not too long ago with a CLL progression. So we're 0 for 2 with the 17p deletions in the treatment naive group, but you can see here with the relapse refractory group, we're down to about 20% at 5 years. What's interesting is when we talk about the CLL progressions, and these are the first 5 patients who developed progression of their CLL on ibrutinib, and all of them were found to have a single base pair mutation. And what's really quite telling is sort of the complex karyotype and the dysfunction in p53. And so those are all things that I think really have to be focused on as areas of basically prognostication. So in looking at the OSU cohort again, we have 308 patients, 10% who discontinued due to disease progression, 13 patients who had CLL, and 18 patients who had Richter's. Of the 13 CLL progressions, 11 out of 13 had a single base pair mutation in BTK or PLC gamma, and in the Richter's, only 2 out of 18. So I think that we have some data that can help us with looking at these patients who are progressing on ibrutinib and whether or not this is a single base pair mutation or not, and we may hear a little bit later about some means for identifying that earlier on. But these are all things that now that we know that these tend to be the 17p and 11q deleted patients, that we can start to look at how we might be able to impact upon that group separately. And I just want to point out that, basically this 3F right here in the pocket, and I can't see which one's the F, is where the ibrutinib binds. And any mutation to that that's going to render it unable to bind ibrutinib will render ibrutinib ineffective. So talking about a Richter's transformation, 2 types, clonally related and clonally unrelated. And of course, the clonally related ones are the ones that tend to be quite poor prognostically. And when you look at the risk of developing Richter's transformation over time, you can see here from time from diagnosis and time from treatment, and we get a plateau maybe of about 10% at 10 years. And when you look at risk factors associated with Richter's transformation, we have IGVH V gene usage 4-39. We have 17p11q deletion primarily, though trisomy 12 is in this group. And you can see CD30 and Notch1 mutation. I really want to focus on the 17p11q 4-39 and Notch1 mutation because I think those are going to be the ones that are going to be more important. So Notch1, we all know, is associated with a myriad of bad outcomes. But remember something, time to needing treatment isn't really a bad outcome anymore, right? If you have effective therapies that are well tolerated, what I really want to talk about as bad outcomes are going to be those people who actually aren't going to have a good response to an agent like ibrutinib. And when you look at the treatment-free survival by Notch, this of course is in the era of chemotherapy, but once again, it's not relevant when we're talking about different therapies that are going to not have the risks associated with chemotherapy. So when we look at Notch1 mutations in Richter's, what we see is that the patients who have clonally related transformed large cell lymphoma actually have a 40% incidence of having a 40% incidence of a Notch mutation. So this Notch mutation really speaks to a large group of the patients who are developing Richter's transformations. And one of the things that's very important about Notch1 is that it's often present at diagnosis. So this isn't an acquired abnormality. And so on day one, when you meet your patient for the first time, you'll be able to sequence their Notch gene and know whether or not this is a fate that they have to think about. And you can see here the cumulative incidence of a Richter's transformation in Notch mutated patients is about 45% at 15 years. And for Notch wild type, it's only 4.6. And what's interesting is when you look at 4-39V gene usage, you can see here the 5-year risk is about 35%. And what's really interesting is when you combine the two, you all of a sudden get to 100% for the Notch1 mutated 4-39V gene patients at 5 years. So when all of a sudden you have a prognostic marker like this, it speaks to the idea that we can actually do something differently for these patients and intervene on them and hopefully prevent that from happening. So the summary in essence is prognostics in the novel era should be who are those patients that aren't going to enjoy long-term survival and remissions with our novel agents. In patients, in terms of response to BTK inhibition, we have a risk of ibrutinib resistance, and we're going to see that primarily in the deletion 11q and 17p patients who actually have complex karyotypes. And then in terms of the risk of Richter's transformation, we have 11q and 17p, and then we have the Notch1 and 4-39. These are the areas that I think we need to use for prognostication, and maybe these people will benefit from early intervention. And so the new high-risk category in 2017, you can see here, is 17p, 11q deletions, Notch1 mutations, and V gene family 4-39s. Thank you.